My name is Dr. Sapa Mansoor and I am a veteran trainee at LRPT. I will be briefly talking about the modern wing systems for the pars plana vitrectomy. We all know that the success of the pars plana vitrectomy heavily depends on the surgeon's ability to clearly visualize the infrastructures of the eye, and this necessitates the use of the modern high-resolution imaging technology to enhance the precision and the outcomes. It is generally divided into conventional and the wide-angle wing system. In conventional, we had a contact lens handheld system, hand-free contact lens, and in the wide-angle view system, it is of contact and non-contact type. The microscope needs an inverter, which are made of prisms. They erect the image, corrects the laterality, and maintains the stereopsis. Stereoscopic diagonal inverter is an example. AVI stereo inverter, which gives a field of 68 to 130 degree. It is in handheld and type and self-retaining ring type. Then we have re-inverting operating lens system. It is designed to correct the inverted image, single element re-inverting prism, and these are the few examples I have mentioned: Mini-Quad XL, Pandora, and Claravate. In the wide-angle wing system, the contact type has a vitreous pan-fundoscope, which gives a view of 130 to 150 degree. It needs an SDI. And second is contact wide field lens. The field of view is 120 to 30 degree. It is held by hand or standard lens ring. These are the types and names. Currently, we are working with the non-contact wide-angle viewing system. The Oculus, the Biome by the Oculus, which works with stereoscopic diagonal inverter. It comes with three models: closed cone, open arm, and foot control motorized focusing system. It has a condensing lens of 130 degree and objective lens with SDI. This is a diagram which shows the parts of the Biome. It has a disposable reduction lens, a drive belt for the motorized Biome, and the HD lens. We have lens which ranges with view from 60 degree, which provides a good macular view for the epiretinal membrane and macular surgery, to the wide field lens, which view ranges from 60 to 130 degree. We have office system by the Topcon. It is an optical fiber-free intravitreal surgery system. It is incorporated with the light illumination, so it facilitates the bimanual vitrectomy. This is the picture. Then we have a EBOS by Hack Street. It comes with two lenses, one 90 diopter for the 90 degree field of view, and 124 field of view lens. This is the picture. Then the RUV 800 by the Leica works similar to the EBOS. The Resight 500 and 700 model by Zeiss, it also holds two lenses, 1 to 8 diopter lens for wide angle field, and 60 diopter lens, which provides high resolution posterior pole image. We have OCT integrated microscopes. It provides an imaging technique that provides real-time and cross-sectional view of the retina. The integrated OCT into surgical microscopes allows surgeon to obtain detailed images without interruption of the procedure. The commercial available microscopes with OCT are Zeiss Rescan 700, Leica Provio 8 with in-focus, and Alcon and Genovity with 3D visualization. This is the picture attached, taken by in real time during this surgical process. ERM in the eye, it is peeled, and then OCT was taken per op. Now we have the True Vision 3D heads-up display system. The high-definition 3D screens present the magnified view of the surgical field. The surgeons can operate heads-up position, looking at the screen instead through the eyepiece, which offers advantages like reduced strain, cause significant neck and back strain due to prolonged period of leaning over with conventional microscopes. So the head-up position mitigate this issue. The enhanced depth perception and the improved collaboration with the assistant trainees and for the fostering better communication or education during procedure. So Microsoft with True Vision systems are Zeiss Lumera 700 and Artivo 800, Leica Provio 8 and Alcon and Genovity 3D visual system. This is the diagram of picture of the Zeiss RTO 800. This is Alcon and Genovity 3D visual system, and this is Leica ProView 8. Thank you.
The next speaker is going to talk about vitrectomy machines, Ali Numan.
Now I'll be talking about vitrectomy machines. I'm Dr. Ali Numan. Starting off with a disclaimer that we do not have any financial interest in any of the machines we're going to be discussing. There are several components of a vitrectomy machine. Major components are an aspiration pump, an infusion system, vitrectomy probes or vitrectomy cutters, endoelimination, diathermy, and endolaser. These are some of the commonly used vitrectomy machines. Starting off with an infusion system, it can be either gravity-fed or it can be an active pressurized system. A gravity-fed system is dependent on the bottle height, and an active pressurized system is either mechanically or air-compressed bottle or a bag or the fluid inside the cassette. With the modern systems, we have a software adjustment for the offset in the height of the bottle or the bag. For the aspiration pumps, we have two different types of pumps. A Venturi pump, which is a vacuum-based pump. As you can see in the diagram, compressed air is sent through the tubing and a vacuum is created, which allows aspiration from the cutter into the cassette and the bottle. The flow is variable according to the viscosity of the aspirating substance. This poses a problem because the vitreous is a heterogeneous substance, and this is why most modern vitrectomy machines have shifted to a peristaltic pump in inclusion to the vacuum-based Venturi pump. In a peristaltic pump, as you can see in the diagram, it consists of a roller with coiled tubing around it. The movement of the roller builds up the vacuum, and vacuum is generated when occlusion of the of the vitrectomy probe occurs. Flow rate is controlled by the surgeon, and vacuum varies according to the viscosity of the aspirating substance. The vitrectomy probes available to the surgeon are mostly of the guillotine type. They can be a pneumatic spring cutter or a dual pneumatic cutter. Most modern vitrectomy machines employ a dual pneumatic cutter. It can have different types of gauges, 23 gauge, 25 gauge, or 27 gauge, depending on the pars plana vitrectomy. The cut rates can go as high as 10,000 to 20,000. A duty cycle is important when we're talking about a vitrectomy cutter. The duty cycle is the percentage of time a cutter port is open in relation to the cutting cycle. Twin duty cycles are used by the dual pneumatic cutters, in which the guillotine has two cutting ends, and this essentially gives us a double cutting rate. A dual dynamic drive is a setting in which the surgeon has separate control of the vacuum and the cut rate. This is controlled by the surgeon through the foot pedal, and this is used by most modern vitrectomy machines. Hypersonic vitrectomy is a recent development. It allows the surgeon to liquefy the vitreous surrounding the probe, and there being no guillotine type inside the cutter, it allows the port to be open at all times, and it gives the surgeon a better and more efficient cut rate. This is a picture of a 27 gauge vitrectomy probe. Coming to endoillumination. Endoillumination allows the surgeon to view inside the retina without external light. All light probes have a heat and UV or infrared light filter. There are different sources of the light. It can be a halogen or metal halide, xenon, or an LED light. There are different styles of the probe or different types of the probe. It can be a straight probe, which allows the surgeon diffuse illumination of the retina, or it can be a bullet probe with which there is focal illumination of the retina. A shielded probe is a modification of the bullet probe. It reduces the glare with the use of a shield. A wedge probe is a hybrid probe. It uses both properties of the straight and the bullet probe, providing the surgeon with both focal and diffuse illumination. Chandelier illumination is of particular importance with diabetic vitrectomies. It allows the surgeon to have bimanual surgery, and it provides diffuse illumination, which causes less phototoxicity to the retina because there is a greater distance between the retina and the chandelier light. This is a picture of a chandelier illumination probe. Thank you.
Thank you, Ali. I think we will have the first talk if it is present, if it is on the system. The first talk, Ran. Introduction.
Assalamu alaikum. My name is Dr. Mohammad Farhan Lodi. I am here to discuss the introduction of advanced diabetic eye disease. Advanced diabetic eye disease is a serious vision-threatening complication of diabetic retinopathy that occurs in patients in whom treatment has been unsuccessful or inadequate. Occasionally, advanced disease is evident at presentation. Some of its clinical features are vitreous hemorrhage, traction retinal detachment, and reverses iritis. Now, the vitreous hemorrhage could be pre-retinal, intragel, or it could be both. Intragel hemorrhage takes longer time to clear than the pre-retinal as the former is more substantial. And sometimes the blood becomes compacted on the pre-retinal surface, and which forms a membrane known as Austrian membrane. Here are some of the color pictures of the hemorrhage, pre-retinal vitreous hemorrhage. And this is the B scan of vitreous hemorrhage, specifically showing hemorrhage and excluding from the any traction. This is moving on to traction retinal detachment. It is the ongoing or progressive contraction of fibrovascular membranes over the vitreoretinal adhesions. And in proliferative diabetic retinopathy, the posterior vitreous detachment is usually incomplete due to the strong adhesions between the cortical vitreous and the vitreoretinal adhesions. And sometimes we see hemorrhage due to the stress exerted on the new vascularization there. Here are some of the pictures of traction retinal detachment, ring of white scar tissue you see there. And this is the B scan of traction retinal detachment along with showing combined detachment. Reverses iritis, it is very common in proliferative diabetic retinopathy, which may lead to new vascular glaucoma, and it is common in it usually occurs in severe retinal ischemia. Now, the indications of pars plana vitrectomy. Vitrectomy in diabetic retinopathy is typically combined with extensive endolaser pan-retinal photocoagulation. Its indications are severe persistent vitreous hemorrhage, which is still the most common indication in which pan-retinal photocoagulation is precluded in type 1 diabetes, in bilateral or in the absence of reverses iritis, and within first 3 months it should be done. And according to the surgeon's preference and the patient's demand. Progressive traction retinal detachment, which is involving or threatening macula, it should not be delayed. However, the extramacular traction can be observed because it remains stationary for a longer period of time. Combined traction and rachematogenous retinal detachment should not be delayed. And premacular retrohighlight hemorrhage, when the blood becomes is dense and persistent, internal limiting membrane forms a membrane, and स्कैफोल्ड बन जाता है, उसकी वजह से इंटरनल लिमिटिंग एम्पीरेटिनल मेम्ब्रेन बन जाती है और मैकुलर ट्रैक्शन डिटैचमेंट हो जाती है एंड एंटीरियर सेगमेंट न्यूवास्कुलाराइजेशन एंड मीडिया ओपेसिटीज. Thank you.
Thank you very much, Doctor, for the very illuminating talk. Now the next talk would be about the steps of general steps of the vitrectomy by Hamza. Meanwhile, he's setting. I'll just ask the chair about their opinion about the viewing system, because I know Dr. Kuram has been doing both biome and IBOS. So any preferences or any comments about which is better or which is?
Yes. When I was in LRBT, I have used that. So we have actually main 4 common ones: biome, IBOS. Leica one is similar to IBOS. Then there is the Resight one, the one on Zeiss microscope, and then there's another one, but I don't know, the office system. The office system one, which provides the illumination from the microscope, and you do not require an endo illumination. So you can perform without the insertion of chandeliers or anything by manual surgery on that. So that's also very useful. It's personal preferences. Biome system is, I think, most common one. If you look at throughout the world, it's used most commonly. And but I find myself iBoss system to be the most convenient one because it has its own automatic inverter already incorporated in it. As soon as you put it down, everything is in focus, and you don't require any inverter. So it takes a little more space, but focusing and everything, I find it to be the quickest and easiest one. So we'll we will see if there's any other opinion. We'll ask Professor Khalid as well.
Yeah, there's a lot of interest, sir. And I will ask you this question from Dr. Khalid Bhai Saab. A lot of interest in the heads-on and the 3D system over the last couple of years, 4 or 5 years. Do you think that they are going to replace the present system, the 3D visualized system with the polarized glasses and the higher magnified things?
I think it looks very promising theoretically, but practically speaking, I think iBoss and biome systems are probably the best ones in use. But technology changes so quickly that we may come up with a better system in future. But at the moment, I think I feel very comfortable using biome. In my hands, I feel I'm very comfortable with biome. But iBoss, I think, is a bit more takes, as Khurram said, takes a bit more room. But having said that, you don't have to fiddle with the SDI and inverter system. So yes, it has its own pros and cons. But for me, biome is the favorite.
Yes, Khurram Saab.
Just quickly about the VR system. We tried a few at Barcelona in EU Retina, and they look wonderful, and people who like video games and everything. But I have my own reservations, which is very strange. Have you ever checked your? Many people are wearing smartwatches these days. Have you ever checked the radiation level on your smartwatch? So radiation level on your smartwatch goes up to red if the Bluetooth and everything is on. And to many people, you can look through the net, it's full of that. It gives headaches, nausea, and dizziness. And since that day, I've started keeping mine on airplane mode most of the time. So most of the functions are not. These VR systems are sitting on your heads. They're running on Bluetooth and Wi-Fi systems. And one person has already checked radiation level on that, and it was very high. So few years down the line, I think nobody wants to accept that. People like even Elon Musk, when he was asked about these things, he totally negated that, but they were there. So all the electronic companies and all that, they are never going to let it come on the surface, but they can be deadly in the long run. So VR surgeons are already looking after their necks and backs. So I think it's time to look after their brain as well. So I'll be very careful about that.
Thank you. That's very valid point. Thank you, sir. So we go on to the next presentation. That would be generally the techniques of vitrectomy in the advanced diabetic eye disease by Hamza Tayyib.
Bismillah ar-Rahman ar-Rahim. My name is Dr. Hamza Tayyib. I'm working as a VR resident at LRBT Township, Lahore. My presentation is on techniques of pars plana vitrectomy and tractional retinal detachment. So pars plana vitrectomy is basically a microsurgical procedure which is used to treat a variety of vitreoretinal diseases. So basically this procedure has evolved over many years and it continues to improve. So firstly, we have to do the pre-operative preparation like in any operation. A good anesthesia is also very important, adequate pupillary dilatation for visualization, and you can do the imaging like OCT, B-scan if the view is clear. So the next step is the surgical setup. So pars plana vitrectomy always starts with good anesthesia followed by trocar canal insertion, infusion line placement, and microscope and visualization. So it depends if the patient is pseudophakic or phakic. You can insert it at 3.5 millimeter or 4 millimeter. Make sure the infusion line is placed well, and you remove all the air from the infusion line, and microscope and visualization make sure all the lenses are clean at the time of visualization and the cornea is clear. So we start with the core vitrectomy. It is basically the removal of the central vitreous. If in tractional retinal detachment, then we try to induce the PVD if it can be induced. We can use triamcinolone acetonide to remove the vitreous. Then we can do the sheath vitrectomy, the peripheral vitrectomy, also called the sheath vitrectomy. The basic principle is to avoid making any retinal breaks and remove as much vitreous as possible. Now, on to the main point is addressing the pathology. Basically, the pathology of the diabetic retinopathy is basically in the posterior segment. So you can, if there are membranes, then you should peel the membranes, apply the laser. Any concurrent retinal detachment, rhegmatogenous, you can treat that as well, and removal of hemorrhage. So tamponade and closure depends on the pathology. The more severe the diabetic retinopathy, the longer the tamponade should be applied. So longer tamponade is silicone oil, shorter is gas, SF6 or C3F8. Wound closure is important in diabetic retinopathy because the healing is slow in diabetics. So key advancement is small gauge vitrectomy system like 27 gauge, 29 gauge even, high speed cutters, I think also ultrasonic cutters, and advanced visualization and fluorescein staining. So techniques there are three basic techniques for removing the membranes: the delamination, segmentation, and the en bloc dissection. Delamination, basically you remove the horizontal cutting of the individual vascular pegs. You try to remove it as a whole sheet. And segmentation, if you cannot remove it by delamination, then you break it up into small pieces, which is segmentation. And en bloc dissection, it is the separation of the posterior hyaloid from the retina. So the tractional retinal detachment surgeries are quite challenging to do, so you should be prepared for everything.
So thank you. That was the theory, and the next presentation will be the video of the surgical technique by Dr. Slan, and that would actually show the different steps of vitrectomy. And we can take any question meanwhile, if there are any questions. We can have an interactive discussion on that. Any questions from the house, from the audience? Please.
Since I can see there are PGs and vitreoretinal fellows sitting here, you should just want to give you a concept about what's latest about the pathophysiology of advanced diabetic eye disease. Vitreous cavity, we all know, has wedge F, but we don't know much about the platelet-derived growth factor. So, advanced diabetic eye disease is a combination of fibrovascular proliferation. So, there's a very fine balance between the concentration of VEGF and platelet-derived growth factor. If you inject anti-VEGF in a diabetic eye, you are addressing the vascular component, but you're not addressing the fibrous component. So the fibrous component tends to dominate in that fibrovascular proliferation. So many times you notice that when you are giving anti-VEGF in a patient who has already started developing some elements of traction, that the traction gets worse because you're addressing the vascular component. Fibrous gets worse, and you start getting more tractional detachment, but less of a vitreous hemorrhage. So there's a sort of a situation in the chemical composition of the vitreous cavity. If the PD, platelet derived growth factor, level is higher, you will have more fibrous activity, and then you will be more inclined towards a vitrectomy, performing a vitrectomy, and that is the solution in these patients, that you have to, surgery is must in those patients. If when you control, when the VEGF level is higher, there's a chance of vitreous hemorrhage, but less chance of traction detachment. So, when you're treating these patients, many times you guys must have noticed that people who had a lot of Avastin injections, it was addressing more towards VEGF. So these patients developed taut vitreous, and they had worsening of tractional retinal detachment. So depending upon the situation in the vitreous cavity, you address these patients, whether they need surgery or they are managed by anti-VEGF?
Yeah, very, very useful point actually, because intravitreal injections are very easy to do and everybody jumps into those. So like Professor Khaled just said, to look at the vascular as well as fibrotic component. So I mean, if you plan to do a vitrectomy and you want to reduce bleeding and everything, anti-VEGF a few days before surgery is well justified. But because the contraction starts a few weeks later, so in that situation, it's well justified. Otherwise, the take-home message was that somebody that has more fibrotic should go for surgery rather than injections. So very useful. Thank you.
Okay, Aslam, you can go ahead with your
Assalamualaikum.
presentation.
I'm Dr. Malik Aslan, Senior Ophthalmologist, LRBT Lahore. Now I'm presenting the video of the diabetic vitrectomy. The surgery is done by Dr. Kashif Iqbal, my supervisor at LRBT. 23 gauge trocar system was inserted and vitrorexis was initiated in order to gain access to the retina and to the fibrovascular membranes. Now checking the central retinal traction and the attachment of the posterior hyaloid is very important in this situations because most of the breaks occur here in the attachment points. This shows the insertion of the chandeliers. Two LED chandeliers were inserted. Now Tamsilon was injected in order to check the attachment of the hyaloid and the posterior vitreous. Forceps were used. Now the segmentation was done by 27 gauge cutter, which is very precise in cutting near the retina and avoid damage to the underlying structures. As you can see, very careful dissection is being done. Patience is of key in this type of surgeries. You have to assess step by step. Now careful dissection has been taking place. You can see how precisely the 27 gauge cutter is dissecting the membranes without damaging the underlying structures. Now air fluid exchange has been done.
So Actually, a
And
lot of people have.
I was left on silicone oil. Thank you so much.
So actually, there are so many ways to do the same thing. Some people prefer other things, but the actual point is that as you are dealing with those membranes, you need to know from which point you're not going to pick that up and do a segmentation rather than using force. Yes, we would like to have comment from our chairs.
It was excellent surgery. Obviously, we are here because we have different ways of operating. Looking at this video, the way I would do it differently is that, especially in diabetics, we know that the main pathology is in the posterior pole, or the most visually significant part of the retina is the posterior pole. So it's for me it's best to start from the periphery and then make your way towards the center rather than making from the center towards the periphery. That's the first basic rule in diabetic vitrectomies. So that you may have a tabletop attachment, and when you are cutting through the vitreous, through the hemorrhage, you may just cut the macula, or a very important part of the retina. Secondly, Kashif did brilliantly with the cutter in one hand and a light pipe in the other. I use 3, 4, 5, 6, 7 port vitrectomies in diabetics. I like to rotate around the patient. During vitrectomies, I sit on the top, I sit on the temporal side, I can even sit on the nasal side. Impossible to sit on the foot side because there's no room. I don't use a cutter when I'm on the macula. I always use scissors and forceps, the old-fashioned way, and I find peeling at its best when you're using a forceps and a scissors, because you're in the planes. And with cutter, the only drawback I feel is that because it has high suction and vacuum, it can just eat away your retina in a second in front of in front of your eyes. Although the most advanced cutters have systems which don't let you do such a blunder, but I've seen people eating away the macula by going so close to the retina. So I don't take those chances, and I find I have had great discussions with the European VR surgeons regarding this. My fellows and for consultants have assisted me. This technique enables us to stay away from any iatrogenic break in traction detachments, and we don't create iatrogenic breaks, just because if you're in the right plane and if you're using scissors and forceps on the posterior pole. I know Khurram has a different way, his hands work differently, he does magic and wonders with the cutter, but I find that that's why we are both here. He will tell you his way of doing diabetic vitrectomies, but I don't use cutter in the posterior pole. Secondly, I never put oil. I never give tamponade to any retinal detachment which is tractional only, right? This is what I was taught, and you fear so much fluid on the posterior pole, whether it will ever go away. Why not drain the fluid and flatten the retina and then put oil? Then obviously you have to put gas or oil. But I find both are toxic. So why to put in anything in the eye when you can get away with it? So I do not put any tamponade at all, and we have done hundreds of cases. Over a period of time, this fluid goes away because the cause of the fluid is traction, and you've got rid of the traction. Okay? And obviously, if you want to put icing on the cake, you can give an anti-VEGF at the end. So now I don't want to take any more time. Khurram, you have.
So we can have comments from Dr. Khurram, especially. What if you don't have if you have an iatrogenic break? Even then, you will not be doing any tamponade.
Of course, I will keep very
Then you are in trouble, because an iatrogenic break in a TRD is trouble, and then you have to do laser or barrage laser around it. And over here at the end, when we saw the video at the end of the surgery, we could have given some barrage laser, but no need to do that because there was no hole, and there was oil in the eye. After a few weeks, after maybe a month or two, if there's still a risky area, that can be lasered on the straight line. About the use of scissors, we can never argue against them, because if you ask even me, I mean, I don't use scissors as much as I used to use scissors with 20 gauge, because with 20 gauge the cutter was very big and the dangers were much more. But so I always use scissors, horizontal scissors, vertical scissors, and even chandelier, both hands. But since the cutters have come down to 27, 25, 27 gauge, the iatrogenic brakes are difficult to produce. But certainly, if you compare the two, scissor is safer. But if you think something can be done with a cutter and it's easier, because now the cutters are so thin, they can go under a membrane. You can lift up the membrane and cut it, so it becomes very safe. So as far as this tamponade thing is concerned, a very, very useful point. Uh, I would not recommend that to people who have started doing this, but as with time, as you recognize the retina and its behavior more and more post-op, this approach of not giving anything, any tamponade, it has no problems. They do get, but keep an eye on the pigment epithelium under that area. If you are doing vitrectomy on a myopic person, then might as well give a little bit of tamponade, because then the pumping force, it's just like ROP. In ROP, all you do is remove the central vitreous and the RPE will pull back the retina. Same over here, but if the RPE is not good in that area and then you can give tamponade, but otherwise it works.
Yes.
I think the take-home message for today's discussion for young budding vitreoretinal surgeons is that it's very easy to be in a delusion by putting oil in these eyes, right? So oil is toxic. Oil is especially in diabetics, who already have compromised, vascularly compromised retinas, and not just the vessels, but the whole retina is compromised because of diabetes. And the oil would only add to the toxicity. And we know that vision in an oiled eye is usually not as good once we remove the oil as you would expect if you look at the retina clinically. So as long as you can avoid, and again I would second Khurram here, because young doctors may have some silent break sitting which they've missed, and they've not put oil because I'm telling them not to, and they develop it's just experience. Once you have done hundreds and hundreds of retinas, then you know that you're safe not to put oil in. But for starters or beginners, I think it's difficult. But I'm an anti-oil person in diabetics. I don't recommend it.
Yes, I agree. Oil gives a lot of inflammation, especially in the diabetics. Okay, another point I will ask the chair about their opinion is that removal, doing a combined phacovitrectomy. I mean, if there is not that much of a cataract, patient is say 50 years old and slight NS1, would you like to remove the cataract along in the same sitting or afterwards?
I always say one thing to my trainees, that I feel that in patients who have advanced hepatic eye disease, lens is protective against advancement of diabetic retinopathy. So if somebody is high risk pre-proliferative diabetic, if you remove the lens within weeks, you will notice that the proliferative disease will set in very quickly. So there is some antioxidant, anti-VEGF element of the human lens which protects this eye from developing an advanced diabetic eye disease. So I would avoid having cataract.
So from your comment please about this.
Yes, same here. But it wasn't like that maybe 15 years ago. In those days, there was a trend of, slight bit of shade in the lens. You're doing vitrectomy, take the lens out and do the whole thing. And I used to do the same, but since many years, because with experience you wisen up, I totally agree. The activity in the eye enhances if you fiddle with the lens as well. You open up the bag, and so if at all you can do the surgery, and you obviously counsel the patient, the cataract will get worse and you'll have to deal with it later on. And if he understands that, leave the lens in there and you do your job. And as well as that, the other reason is that you're going in doing this complicated case, you are not sure. You may require tamponade, you may require gas, you may require oil, and then you may have to posture the patient a little bit. And when you've done an IUL and posturing, pupil is always stuck down in different places. It's usually stuck in dilated position or something like that. So avoid it if it is easily possible. No need for this unnecessary
So
intervention.
the take-home message is avoiding the combined procedure. Any comments about, sir, ILM peel in those cases? Would you be doing it in routine or any special circumstances in which you would be doing an ILM peel as well?
Again, I am my reservations are different, maybe different from Khurram. I am against peeling ILM in diabetic patients. You mean diabetic patients with maculopathy, or just as a standard?
Well,
peeling?
standard, some
No,
people-
I think their studies have shown that ILM peeling has no advantage in the final visual outcome of patients. Rather, it is actually a disadvantage in a lot of patients. ILM in a sick diabetic retina behaves very differently from a normal ILM because it is more sticky, and the layers of retina underneath the ILM they are also diseased, so they are more sensitive to touch and traction. So when there's no point in pulling a membrane over a sick retina, why to do it?
No. Khalid is wrong in one thing. He's wrong that I may have a different concept in this one. No, I'm totally with him on this one. No need to do extra fiddling on the macula. Looking at this previous video, there was traction on one side, the foveal area was intact, and when there is traction on one side, even that ILM will not be a macular hole ILM. It will be rigid. It may pull off that fovea, and the things will never be the same. So trying to save one thing and destroying the other thing. So yes, I totally agree. No need to go for unnecessary ILM fiddling. In future, with the new faricimab Vabysmo injection, which deals with not only VEGF but Ang2, angiopoietin receptors, and when we get in habit of using those, I've started using that a lot, and the amount of ERM and such ILM problems you will see will be much less, because it actually reduces that proliferation on that level. So something for future.
Any
बिल्कुल भी नहीं करनी।
very burning question actually.
विट्रियस बेस देखो, ये पेशेंट्स जो हैं डायबिटिक्स मोस्टली ये फेकिक होते हैं काफ़ी हद तक, ठीक है। सो फेकिक में आप एक चीज़ को कंट्रोल करते हुए लेंस को विट्रियस बेस को शेव करने के लिए यू आर गोइंग टू बी वेरी क्लोज टू द लेंस एंड यू आर वेरी लाइकली टू prang the lens and cause a cataract, and that will, तो बिल्कुल विट्रियस बेस तक आने की ज़रूरत बिल्कुल नहीं होती मेरे ख्याल में, ठीक है। पैथोलॉजी ज़्यादातर पोस्टीरियर पोल पे होती है। आप विट्रियस को शेव करें, इक्वेटर तक कर लें शेव, क्यों आपका क्या है? अगर सूडो फेकिक है तो बिल्कुल इंडेंट करवा के फिर उसको पूरी शेव करें। लेकिन जब मैं फेकिक का सिनेरियो बता रहा हूँ, फेकिक है तो बिल्कुल मेरा ख्याल है कि मैं नहीं करता बिल्कुल।
Half and half. I always change hands to complete the vitrectomy on the sides. You can do a lot with if you're right-handed, you can do a lot with that, but obviously you can't cross the lens in the center. So you change your hands and you can still do a lot. I try and do as much as possible, but we know that the most important thing if you're doing a diabetic vitrectomy is to complete your PRP. You have to do peripheral laser. So that peripheral laser will protect that retina very well. और उसके बाद वो contractions वगैरह उसके काम नहीं आती. And that is one thing one should keep in mind. If you're doing a proliferative diabetic vitrectomy, you have to do a good PRP during your surgery. There is a trend. I've seen people do this vitrectomy and plan the laser for slit lamp later on. That is not a good idea. You should do it during surgery.
Actually, the term peripheral vitreous shave, different people think differently about that. A peripheral vitreous shave. But as the chairs have pointed out, it is better to be safe. I mean, you can't leave any vitreous over there, but not as strongly removal of the vitreous as you would do in a peripheral tear or something in a rheumatous detachment patient. Especially in you have to preserve the lens as well. Yes.
One thing is for sure that obviously you use the triamcinolone to highlight the vitreous. So उसमें आपको जितना नजर आ रहा है vitreous वो आप remove करें. लेकिन over the top vitreal retinal surgery में याद रखें कि मैं अपने स्टूडेंट्स को भी ये कहता था कि हीरो बनने की जरूरत नहीं है, क्योंकि जो पर्पस अगर आप अचीव कर रहे हैं उससे एक स्टेप आगे जाने की कोशिश ना करें, बिकॉज देन इफ यू स्टार्ट हैविंग कॉम्प्लिकेशंस देन आपका सारा प्रोसीजर जो है ना वो डाउन द ड्रेन चला जाता है.
Any more question or comments? Okay, one last questions, please, because the next speakers are over here.
होने का चांस उतना नहीं होता. वो ये तो बहुत कॉमन सिनेरियो है कि यू सी दैट स्ट्रिप ऑफ ब्लड इंफीरियरली, बिकॉज सारा ब्लड ही नीचे जाके इकट्ठा हुआ होता है. सो और हमारा मेन मकसद उतना बल्क विट्रियस का हटाना होता है विच विल नॉट कॉज ट्रैक्शनल डिटैचमेंट लेटर ऑन. ठीक है ना. वो सोर्स नहीं होती ब्लीड की सोर्स तो पीछे कहीं मिड पेरिफेरी या पोस्टीरियर उसमें होती है, वो जाके इकट्ठा हुआ होता है नीचे. सो मैं एक चीज़ ज़रूर करता हूँ कि कोशिश तो करता हूँ कि जितना क्लोज एज पॉसिबल, लेकिन एक जगह के आगे डेंजर हो जाता है कि आप फिर वो ना कर दें. मैं वो ऐसी जगहें हैं जहाँ मैं एक आध उसके पीछे ब्लड के पीछे बाहर से क्रायो आखिर में ज़रूर करता हूँ कि वो जगह अगर कवर नहीं हुई भी और वहाँ से कोई खिंचाव आता है कुछ आता है तो वो जो एक आध स्पॉट क्रायो का है वो उसको काउंटरैक्ट कर लेगा. क्रायो बिकॉज यू कांट डू लेजर थ्रू ब्लड बट यू कैन डू क्रायो.
अच्छा, उसमें बात ये है कि जो फ्रेश ब्लड होता है ना ये नहीं होता कि वो आप वो यू आर एबल टू रिमूव इट विद अ कटर, और इसमें इंडेंटेशन आप ज़रूर करें, क्योंकि कई दफ़ा आपका व्यूइंग सिस्टम में आपको आप यू कांट गेज के इसके कितना डीप आप जा रहे हैं. सो अगर आप इंडेंट कराते हो ना तो फिर आपको बहुत 3D इफेक्ट मिलता है कि और बहुत आराम से आप रिमूव करते हो. और बेटे द इंफीरियर ब्लड इज ऑलवेज देयर इन फ्रेश ब्लड बिकॉज द ग्रेविटी टेक्स इट इंफीरियरली, सो हमेशा ही मिलता है आपको एंड यू शुड रिमूव इट. अच्छा, दूसरा बहुत इंपॉर्टेंट डिस्कशंस जो हो रही है इसमें लेज़र. आई डू वेरी एग्रेसिव लेज़र, you know, to the point of white spots. You know, this is your only and the best chance to treat this aggressive disease. And the more laser you will apply, the more the chances of your successful surgery. Seriously, I do as much laser as I can. You know, peripheral, posterior, everything. Obviously, outside the arcades. And believe me, don't be. You have to be very generous in putting stronger laser burns. कुछ नहीं होता, आंखें बच जाती हैं, रीब्लीडिंग नहीं होगी, वो मतलब सटल ब्लीड होगा, ठीक है, लेकिन वो खुद ही एब्जॉर्ब हो जाएगा. So ये बहुत important, very very important part of this discussion is that do very aggressive laser in these patients because you're in the eye where you can reach now. You may not be able to reach when the patient has had surgery.
Complete PRP.
Thank you very much. I think the next session is here. The speakers from the next session are here. Thank you very much. It was very nice to have a very interactive session. Thank you very much.